All right.
Hello, everybody. Thank you for joining us today for the first parent education support group back for the fall in September 2019. And I'm joined today by Paula Broussard with Speech Pathways Plus, and she's going to talk to us a little bit about what parents need to know about speech, PT, and OT. But I'd like to give just a little bio about Paula. Paula's the owner of Speech Pathways Plus with over 20 years of experience. She has been a speech pathologist specializing in pediatric feeding and swallowing disorders, and she provides special therapy for swallowing dysfunction, oral aversion, oral motor weakness, picky eaters of all ages, and in addition, she also specializes in apraxia, dyslexia, deep
pharyngeal neuromuscular stimulation.
That
Fancy word for gag therapy.
Very good. And many other therapies, and Paula has a wealth of information expertise to share with us today. Thank you for being here, Paula.
My pleasure. Thank you for having me. Good morning. How is everybody doing today?
Good, doing good.
This is such an honor to be here and to provide information to parents that need it on rehabilitation services. Sometimes they'll hear things like they'll outgrow it, or this is the best they can do, and never do we accept those statements from physicians or anybody in the community, not just physicians, because I never limit a child by what I don't know, ever. If I think they can't and I don't push that limit, then they can't. So what I try to do is I push every button, every limit, so that they reach their maximum potential, not what I think their maximum potential should be. So what I want to do is just talk a little bit about the services we provide, and just give you some information about the clinicians that I work with. So my therapists and my clinic are trained in a variety of specialty areas so that we can provide high quality, professional therapy services to help our patients and clients achieve maximum potential. Combined, therapists in my clinic have over 80 years of experience. We've been around for a little while, have lots of trainings, we have a huge bag of tricks to pull from, and we also have each other to bounce ideas off of to help patients reach their maximum potential. We can target specific needs of each patient in a minimum amount of time because our services are intense. Services are provided in a timely manner, in a friendly atmosphere, so that families receive that personal experience, so that when you leave my clinic, you feel like your family. And that's what we want to provide for y'all. So we serve a variety of settings. Everybody goes, speech therapy does that? So what I want to do today is just kind of give you some ideas on what speech therapy actually can do. This is a very limited list. We actually provide services based on training in a variety of different areas. We can co-treat with OT and PT. We can supplement what physical therapy and occupational therapy do as a team approach. Parents, physicians, nurses, rehabilitation specialists, all of us together combined make a formidable team to help patients move forward in where they need to be, okay? So one of the things we address is aphasia. So aphasia is more for adults usually, but not always. When you think of aphasia, you think of an adult who's had a stroke. Well, I worked in a pediatric facility for a long time, and kids have strokes too. And it's very sad to see, but it happens. So with aphasia, what happens is there's two areas of the brain that can be affected, and they either understand what you say and can't put it out. And when I say affected, I mean for communications. They understand, it all goes in, and nothing works. Or they have no idea what's coming in, and so what comes out is not monitored, and it doesn't make sense. Or both areas can be affected in a diagnosis, and we usually use information from physicians onto what brain areas are affected. And so when that happens, I have to literally fix what I call I-10. If you've ever driven on I-10, it's always under construction. My job, and I know it's taken 20 to 30 years for I-10 and it's still not fixed between Lake Charles and Beaumont, trust me. I want to reestablish pathways for the brain and the oral motor functions for speech. So one of the other things I do is apraxia, same thing. But apraxia doesn't have to just be verbal apraxia. So what happens with apraxia is this works beautifully. I know what's coming in. This works beautifully. I can say anything I want to say. However, this is even worse than I-10. This is 288. If you've been on 288, it's a nightmare too. This is 288. So what happens is the motor planning for speech is affected. Apraxia can also affect limbs, which we'll get into for OT and PT. It can affect hands and reach and movement and activities of daily living. And it can also affect gait or walking, how you walk. So for me, for apraxia, what I do is for motor planning is I help establish muscle pathways. So let's talk about a muscle pathway. How I like to present this is you reach for a glass of water and your body knows where to go and how to get it. Your kid reaches for a glass of water. Well, you know, for the first couple of months, they're doing just fine. And then all of a sudden, every time they reach, they knock it over. What has normally happened is, if they're not cutting up, is they've had growth. They've had growth happen. And so they get to the glass maybe a quarter of an inch or a half an inch quicker than they did before. And so now, instead of their original motor programmed reach for that glass, it's changed. And they knock things over. And so we think, oh, good grief. But it's literally a motoric change in their body. So when I say, when I look at kids who walk, and when you see them walk, their feet do this. It just looks like their ankles aren't screwed on tight enough, okay? A lot of times, again, we've had growth happen, and their motor planning can be off. They quickly adapt, but how many glasses are they gonna have to spill before that adaptation comes on? So I take the same premise, and we use motor programming for the face, for the mouth, for the lips, and the tongue. So we have, I do a specific program that works on motor planning or motor placement. So if some kids do something called all or nothing, we go all the way or we do nothing. Well, that can happen with the jaw or the tongue as well. You go open or you go closed. So if you sit in closed a lot, kids are thought to mumble. I can't understand you. Now in adults, I cannot fix those armchair people who sit in that chair with that remote. Honey, I need some water. Can't fix that one. But in kids, sometimes they don't do it, what we call grading. So when you grade, let's talk about the arm just because it's easier to see. When you grade, this muscle is getting longer, this muscle is getting shorter, and it's a slow movement. Well, sometimes we need to work on that slow movement in the jaw so that kids can do what they need to do with speech. So when you work on that, the other thing that has to happen is if my tongue does all or nothing, or it doesn't separate from the jaw, so if my tongue doesn't leave the jaw, it literally sits there and it affects articulation or how we make sounds. If your tongue can move while the jaw is stable, then we get much clearer, much better speech. And so what I do is I train the muscle patterns. So if you're presenting a sound like this, my cue is open, and then sometimes that cue is enough to facilitate a correct production. And they think, oh, wow. And the reinforcement is they get their needs met better in their environment because they're now understood. So when I see patients, like I've had a couple of patients come to me with one word and they're 2.5. So that. Tongue goes up, but it's flat. It doesn't leave the jaw much because the jaw's coming up with it. That. So mama is daddy, daddy is daddy, water is daddy, lights are daddy, everything becomes dad. So my job is to take that speech pattern, expand it so that they can have words. And usually within 3 to 4 weeks using this motor planning skill that I do, they've got words that are manipulating their environment already. It decreases frustration for the patients or clients. It decreases frustration for the parents. It decreases frustration for the child care facility, whether it be home, daycare, whatever, or anyone else who interacts with the child. It also increases family interaction. Grandma's like, oh, I can talk to him on the phone now. Well, that's a big deal for grandparents and kids. So that's apraxia. Okay, articulation I've kind of touched on a little bit. Articulation is one of the things people think speech pathologists do. Articulation. We fix those R's, those S's, those L sounds in kids in school, and it sounds cute. So I have a mom right now who is videotaping her little girl every day because her mispronunciation of R is cute. And yes, it is at 4 or 5 or 6, but it's not cute at 12, 13, and 14 when you're getting teased, or you have to give a presentation in the front of the class, and you're in 3rd grade instead of 3rd grade. It makes a difference in a kid's self-esteem and how they present themselves to other classmates. So we work on articulation skills. It's a whole lot more than those 3 sounds. Some kids have many sounds that are interrupted. Some kids have vowels that are interrupted. If you can get the vowels to kind of regulate themselves, intelligibility will improve quite a bit. You know, so I want a ooth. So I want a juice becomes much more recognizable than ah. So sometimes just giving some vowels in there will increase intelligibility for the parents and for the child. And so articulation is kind of the meat and potatoes of what we've been doing for a long time. But there's a whole lot more to go, okay? So we also work with children on the spectrum. It's called ASD, Autism Spectrum Disorder. It's been called many things over the years. ASD is where it's now. There are different levels of autism and what we perceive as disordered or different. So some children with autism, of course, it's based on cognitive levels. It's based on communication skills. It's based on behaviors. It's based on self-stim behaviors. There are wonderful programs out there now for these children through ABA. And so they can get help that they need before they have to go into school. And it's a really good, solid foundation for these little ones to be able to succeed in the school setting. So dyslexia. Everybody is confused about what dyslexia does. And now, I can't diagnose dyslexia. That must come from another resource. However, I can treat dyslexia. I am personally trained. I've taken training from the Dyslexia Institute. I provide training in reading comprehension, spelling, and all those rules that sometimes kids know but don't know they know. For example, I teach plurals with cookies. It's really fun. Kids love it. So if a kid says cookie and I hand them one, they know cookie and what. But one day they're playing with sounds, or I say, I have cookies, and they come up and they say, cookies, and I give them 2. That is serious reinforcement for an S at the end of the word. So the next time they may try something different. Candies. Again, it's just a specific plural. Did I tell them S on the end of the word means more than one? No, but I'm teaching a rule that will help them get through things. Another one of those little things that we take for granted is past tense. And so it's not just past tense. So let's talk about the words that change completely. So I go, we have gone, we went. Okay, so you've got have and gone, so you've got different things in there from a language and grammar structure for correct writing ability or speech production. And so those rules come into effect. For spelling, when do we double this letter? Why does E-I-G-H say A? Who decided E-I-G-H-T is 8? That confused, in a kid, A says A, T says T, 8. So it can be very confusing. And so we take what kids who have the dyslexia diagnosis, or even not a diagnosis, if there's a reading comprehension issue or a spelling issue, I still use the same program because the language teaching is the same. Okay, so one of the other things we have is feeding. Carrie talked a little bit about what my expertise is in. I've been a feeding and swallowing specialist for a long time. And people think that swallowing, oh, they choke every time. They choke every time. Well, yeah, that's one of them. We have information. We have videography that we can use in something called a video fluoroscopic swallow study, or a modified barium swallow, which looks at swallow function. So if I can get it into the mouth and I can get it to the back of the throat, once I swallow, what happens? Because the mechanisms in your throat are very close together for breathing and for eating. The esophagus and the trachea share a wall, so that you're going, well, I can see how they can choke on liquids or things like that with food. So it makes it, so we have to look at that from a evidence-based or from a mechanical side. I don't have x-ray vision, my glasses are broken this week. So that's one of the ways we can talk about for swallowing. For feeding, there's a whole different thought process on how we work on feeding. Occupational therapists also work on feeding, which we'll talk about. For us, my goal, if I have to work on hand to mouth, in other words, from the plate to my mouth, I will, but I will usually refer to an OT and we work together as a team. From the lips to the back of the throat, I work on that intensively. So what has to happen for me to chew things? So number one, I have to be able to put it in my mouth. Number two, where do I put it in my mouth? Those are things that I look at when a child starts feeding in my clinic. Do they always feed to the front? Do they feed from the side? Do they only chew on one side? Do they chew up and down, or do they use a rotary motion here? If they only chew on one side and they do a rotary motion all the same way, I'm looking at orthodontic needs later on because there'll be shearing of the teeth. So these are all things we look at. Can the tongue take what happens in the front of the mouth and move it to the back of the mouth? Can the tongue move the food from side to side? Can it get the food, once it's chewed, from the middle of the tongue back for the swallow? Can I build up something called intraoral, inside the mouth, pressure to facilitate the swallow of food and liquid? All of those things come into play. I know, and everybody's gonna sit there now and go, do I do that when I eat? And it's perfectly fine. Usually I talk about feeding while I've given you a snack, so that you can go, oh, she's right. I love to hear that. Oh, she's right. So that we can put this together, and so that I can give you some ideas on how it all works. The other thing that I do is oral aversion. And people kind of look at me funny. I am the ultimate picky eater. I'm probably one of the only Cajuns that don't eat onions in things. I will tear up onion rings, however. They're cooked and they're breaded and they're fried. So I am a very adamant clinician when it comes to oral aversion. So in oral aversion, a lot of times is people have told the parents, you have to make them eat. So food becomes the battle. Kids can't control a lot of things in their lives because they're kids, but they can control what passes their lips. So sometimes that's the only thing that they can control, and then oral aversion starts to develop. So what I do is, I tell parents, I said, if I go outside and I get a cricket and I serve it up in some chocolate and I put it on a plate, how do you feel about eating that? Is it still a cricket? I don't care what you cover it in. You could serve it on bacon. It's still a cricket, okay? When you're asking a child to eat something that they are orally aversive from, you're literally asking them to eat a cricket. So what I do is I work on a program that is much less intimidating. So in a feeding scenario, child, parent, If it's a battle, the child's backing up and the parent's coming forward. The child's backing up and the parent's coming forward. So that, that might makes right. You're going to eat this. No, I'm not going to eat this. You're going to eat this. So I have to break that pattern and break that scenario. Because what I want is the child is coming in to look at what's on the plate. I'm coming in and we're doing this together. So how do I change that? So I use a different approach, and it talks about food as not being the enemy. We work on kisses, we work on licks, we work on smells, we work on touches, we work on a lot of things. If you can't get past the smell of something, then think about it. You pass by a place, your mouth starts watering, your smell is so good. Italian restaurants, for some people. But when somebody who has oral aversions walks by that same restaurant, they get nauseous, they start gagging, so things like that can happen. And so we have to come up with a happy medium to find out what's good for them, what's safe for them to eat, what they like to eat, and I can expand horizons that way. And I do oral aversion on any age. Most people think it's the 2 and 3 year olds, but it's not. It's not. I have gotten 13, 14, and 15 year olds to eat so that mom is not making 2 or 3 separate meals because this one won't eat this and this one won't eat this. Or this one lives on cereal and milk because they can't handle some of this stuff. And so I work on that. Some plans are longer than others, but you have to start where the patient or child or adult is. And I will tell you just my own personal experience. I moved to Texas in 1998. And they put something on my plate that was green and smushy, and they served it with tortilla chips. I said, "What's that?" They were like, "Oh, Paula, you're in Texas now. It's guacamole." I'm like, "Not on your life." So I have been trying since 1998 to tolerate avocado or guacamole. When I moved here, it couldn't be on my plate. It couldn't be in the line of sight. I had aversions to this, but I had a semi-traumatic experience. It wasn't really a traumatic experience, but in my head it was, of somebody smearing avocado all over something and it froze. Well, it doesn't freeze. Its content is fat, and so it just kind of crystallized. So there was my image of an avocado. So I had something to pull from, and I knew that was something I didn't want to eat. So now it can at least be on my plate. It can be served by accident. I am adult enough to scoop it out and move it over. I have tasted it 3 times. We're still working on that. But look at the long time that it's taken me, because everybody says avocados are good for you. Well, that was the wrong thing to say to me. Because as being from South Louisiana, we fry everything. Fry that avocado and maybe. And having said that, Red Robin now fries avocado and puts it on a burger. So I might try it that way. So oral aversions are very real. I call them picky eaters, and there is hope, and we can help. We can also help with kids who are not able to move past different stages. There is smooth puree, lumpy puree, puree being applesauce, baby food. Sometimes they can't get past that texture because they're gagging. So I have ways to help kids get past that struggle when you put texture in what I eat. So oral aversion feeding. Oral placement. I talked a little bit about oral placement. I use a program called Talk Tools. You haven't Googled it, your kid's got some issues, Google Talk Tools. It's a very good website. They actually have parent-friendly information that can help you, and it talks about oral placement. It talks about muscle programming. It talks about hitting targets for speech sounds. And so this is a very intensive part of what I do in my clinic for speech therapy. I get the muscle planning moving, then sometimes the sounds will come in. I don't even have to address specific sounds, because usually when there are arid sounds, they have similar oral placement strategies to move them through. Again, it can be jaw placement, it can be tongue placement. Sometimes the tip of the tongue wants to stay up and the back of the tongue stays down. So you have R problems. Sometimes the back of the tongue comes up. All the kid can say is K's and G's. Everything is K's and G's. And the tongue tip doesn't come up for R, a T, D, S, L, N. All of those sounds are tongue tip elevation. How do I do that? So that works for oral placement. Fluency. So stuttering is one of those things that people would love to be able to cure. To date, if they are true stutterers, stuttering will go through cycles. There will be times of very fluent speech, and there will be times of very disfluent speech. And those things, what we do in this arena is we train compensatory strategies or ways to move past the tense muscles that what we call a block. I want to go to the store, okay? And that's just a basic disfluency. They can happen in conjunction with voice raises or pitch raises. I want to go to the store. They can happen with complete blocks. All of this gets tense. How do I help them relax to get through that block? How do I help airflow move forward so that they can have much more relaxed, less difficult speech? And so that's what we work on when we work on disfluency disorders. So, tongue thrust. Tongue thrust is one of those things that usually perseverate in two ways. So you have swallowing issues because you're doing what we call a reverse swallow pattern. Not always, but usually a reverse swallow pattern. You push on your tongue, 500 to 2,000 times a day. On your teeth with your tongue. What are the teeth going to do? They're going to start moving. One of the things that we talk about is soft tissue will move structures. Structures being teeth, bone, jaw, dentition, all of those things can be moved by soft tissue. If you continually push on the front teeth, they will start to protrude. And what I tell parents is and this is basic, average, normal feeding and swallowing kids. I try to get rid of the bottle and the pacifier at around 12 months of age. Because when you go past that, what do they start doing around 12 to 13 months? They start talking and they start playing with sounds. So if you have a bottle or a pacifier in the mouth and they start talking, the tongue stays in a very thick position. Doesn't come out of the jaw, the tongue tip elevation doesn't happen for sounds, and so that can perseverate articulation issues later. Not always, just saying that that's usually how it goes together. So that also includes digit sucking, fingers, thumbs, things like that. And so when it comes to that, we have a series of intensive treatment programs for tongue thrust or reverse swallow pattern. Again, I go back to my oral placement treatment. How can I facilitate the tongue doing what I needed to do, coming out of that jaw, and not this open mouth posture? Okay. The other thing in tongue thrust is that cute lisp. Now, I'm going to date myself here because in an episode of the Brady Bunch, way back in the 70s, little Cindy Brady had a frontal lisp, is what we call it. So her F's sounded like this. And the episode, a child a little bit older than her, teased her in little ways like, baby talk, it's a wonder you can walk. Google that if you haven't looked at it because it's real. I think it was the first form of bullying on TV, if you think about it, because he teased her. But that frontal lisp can happen from the reverse swallow pattern or digit sucking or pacifiers later than that time. It doesn't always. I'm just saying when we look at things, sometimes we can tell from the history. The other thing that happens is when they do bottle or pacifier to like 2.5 or 3, and now again, this is normal developing children. For kids who have special needs for feeding and a bottle or something like that is the only way for them to get nutrition, that's a totally different makeup for a tongue thrust. Kids with cerebral palsy, kids with Down syndrome, those are things we look at a little bit differently than just normal developing kids. So we look at that and we work on moving things around. But what you will see is the teeth start, instead of being nice and round and coming across like this on the maxilla, they start kind of pointing a little bit. So if you would look in their mouth, you would see that their palate is very high and narrow, because what shapes the palate when you're young is the tongue as it moves into your palate. So it shapes the structure. So tongue thrust is one of those things that we can address in speech therapy services. Then voice. So a lot of times we get voice clients who are adults. Teachers, presenters, because they will speak from here. And they will speak when the air runs out, and then they will go into vocal fry. So that's horrible for your vocal folds. So what happens, and people just laugh at me for this demonstration. So this is your vocal folds nicely vibrating at the intended frequency, duration, speed, air support in a normal voice production. When you present or when you talk at an abnormal production or that vocal fry, this is what your vocal folds are doing. No better explanation than that. So when that happens, and you can see just those few times, my hands are red here, that can produce vocal nodules, calluses, if you will, blisters, bumps on the vocal folds that stop them from coming together. So instead of a nice volume or presentation voice, and it doesn't have to be presentation, it can be anything. If you're one of those parents who need your children's attention by speaking very loudly, it can also cause vocal nodules. It's called vocal abuse. There are a bunch of things that cause vocal abuse for adults. What we look at specifically too, though, is in children. Vocal abuse is those kids who keep screaming on the playground. Bantam League, I don't know what they call it now. It used to be called Bantam League, which is the mini football league cheerleaders, who cheer from way up here. Instead of using supported breath, they can get vocal nodules. It can be kids who have allergies and are coughing all the time. It can be someone who has sinus drainage and they just clear their throat all the time. These things can all cause issues with the vocal folds or affect voice. We also address voice when it's strained or tight, so that we have to relax or relieve this area. We can address voice for, if a lady has a voice that's really deep. They call my mom yes sir on the phone all the time. Now, having said that, my mother had vocal nodules removed, so her vocal folds are a little thicker. Hers came from coaching softball. You could hear my mama in left field from the dugout, and nobody batted an eye. So those types of things are considered, and you don't think they're vocal abuse. No, I wanted your attention. I got it. But how? So those kinds of things help. So we also help if you have that low voice and you want to come up a bit. If you're 6'4", man, brawl, and you talk like this, Aaron Neville, I just use Aaron Neville as an excuse, and you want to speak in a deeper tone, we do that too. A lot of times insurance companies don't cover that, but is it an option through speech therapy services? Yes, it is. Okay, so wow, I've given you a ton of information on speech therapy, but I do want to touch on OT and PT just a bit. I am not an occupational therapist or physical therapist by any means. My best friends are OT. I have an OT best friend and a PT best friend, and I have ADHD. So if there's someone out there with a diagnosis of ADHD, you too can be a licensed professional and do presentations with ADHD. It's only limited by the support you don't receive. And there are people out there to help you with that for support. So when I got bored, or when my ADHD was kicking in a little bit, I would learn things. And so I went to continuing ed with our physical therapist. I went to continuing ed with our OT, occupational therapist. And so I learned a lot because I can facilitate what they're doing in their therapy sessions, and it also helps me in my therapy sessions. So one of the main things, people think occupation. Kids? What's a kid's job? To play. A child's job is to play. So I have to teach through play. And we do a lot of that. So if your kid comes out of one of our therapy sessions, PT, OT, or speech, and they say, Mama, we played. You bet we did. You bet we did. But I taught them something along the way. Don't tell them that. So occupational therapy looks at activities of daily living. What is that? What is an activity of daily living? Did you put your pants on in the morning? Did you put a shirt on? Did you brush your teeth? Did you eat? All of those things are activities of daily living. Did you button your shirt? These things are all things that occupational therapists thrive in. They help patients do this very well. So in these activities of daily living, if your child is struggling with just getting dressed in the morning, that's OT. If your child is struggling with feeding, hand to mouth. OTs also do feeding and swallowing. Most OTs that have been trained in feeding and swallowing are excellent. I just happen to speak on it because it's what I do, but occupational therapists also do feeding and swallowing. Okay, so, but what we work on with our OTs was hand to mouth. Can I stab that and put it up here? Do I have to grab it? Can I pinch it? All of these are developmental skills for feeding. I have to be able to pick it up and eat it. I have to be able to chew it. I have to be able to do those things. Another thing for occupational therapy is sensory integration. You have that kid and they do this all day long. The tag in their shirt is driving them crazy. Thank God for Hanes. T-shirts with no tags. Not trying to promote an object here, but T-shirts with no tags. These kids may not walk on grass barefoot. They may only walk barefoot. Sensory integration helps them to assimilate all of the input from their environment, regulate, in other words, keep calm, and move forward. And I don't mean just walking, I mean move forward in anything that they do. So sensory integration is very real. Sensory integration is also a component of feeding. I don't like the way that feels in my mouth. I don't like the way that smells. I don't like the way it tastes. So they put together what's called a sensory integration diet. It has nothing to do with food. It might, but it has to do with sometimes if I use a weighted vest, kids can calm. Sometimes if I teach in a swimming pool, kids can learn better. Sometimes if I provide a wiggle cushion, just so something's moving, I can learn. These are all part of things that OT can do. Fine motor skills. One of the things that I recommend for OT is handwriting without tears, or a structured intervention to help kids write. And sometimes it has nothing to do with the hands. Sometimes it has to do with stability, where your shoulders are, where your hips are, how you sit in a chair, or you have that kid that lays down on the table and writes. So these are all things that kids do to compensate to perform the activities that you want them to do the best that they can. So these are things that occupational therapists can do. Upper body strengthening and movement. So sometimes, and I'm going to put this in OT, but I'm also going to say it in PT as well. It's cute when you're 7, 8 month old, instead of crawling, is scooting with their legs across the floor. They're actually sitting and using their legs to scoot. Okay. Yes, they are mobile at this point, and they can get from point A to point B. But the benefit of crawling is what people don't always get. Okay. So when you crawl, upper body stability, upper body strengthening, upper body, so the shoulders will start rotating down, move into the place they need to be for stability for arms and hands for writing. So think about it. Now PTs will address, and OTs can address it too, but they will address the movement to get them in what we call quadruped, all fours. How do I get them up here? Even if I just get them up here to rock. If they want to be mobile the other way, but even if I can get them up here to rock, just so I can get this sensory input and the strengthening for shoulders and upper body. Adaptive equipment. Sometimes, through no fault of their own, people have things happen or disabilities occur, and you need help in what you do. You are in a wheelchair and you need to reach what's on that shelf. OTs can help with the grabber to get what's up there. You have a stroke and you can no longer use the right side of your body. OTs can help you in your job with a left-handed keyboard. So all of these adaptive equipment things people don't think about. If I can find, if a physical therapist can put them in a nice wheelchair, I can get a great communication device that, oh, this is going to be fabulous for them. But if they can't access it, I've done nothing for my patient. Absolutely nothing. They have to be able to access it, and that's where OT can help us. So it's usually a joint effort when it comes to those kinds of things. OTs also do something called serial casting. Okay, everybody is, huh? So what happens is sometimes kids with special needs are born and they don't get the movement that other kids do, and so they start fixing in a position. Okay, so this is the position. And I use this position because I've also had a kid that we were able to serial cast him out, and he could actually play and interact with the mobile on his bed for the first time after serial casting. This was his position. So what they did was a gentle stretch, serial cast. Gentle stretch, serial cast. Gentle stretch, serial cast. So we facilitated the movement and kept them in those gentle stretches to kind of help get extension in the arms so that they could start using their arms instead of locked in this position. It helps with bathing. It helps with mobility. It helps with doing self-care. All of those things can come just from serial casting. It also works on legs and things like that. I mean, we also serial cast other parts of the body. It's going to shift real quick into physical therapy. So physical therapy is what most people think about when they think about rehabilitation services. Because if you can walk, life is grand. So physical therapy, they're not primary, that's a misconception, sorry. What a physical therapist, everybody thinks of is mobility. Walking. Can I walk into McDonald's? Can I walk into the grocery store? Can I walk to the restroom in my house? Mobility. It doesn't have to be walking. They also work on mobility with adaptive equipment, a walker, a wheelchair, and anything in between all that. I'm not giving a full picture. Again, I'm not a physical therapist. I just wanted to touch on some things that physical therapy does. Gross motor movement. Gross not meaning disgusting. Gross meaning big. Big motor movement. So if I need a kid to be able to stabilize, I need them to be able to sit up, have their hips in the right position so that I can do what I need to do for feeding. So I talk to my PT, I need hip stability. I need them to be able to sit. I need this to facilitate safe oral intake. So my PT and I can work together and we can work on these big muscle movements. What else do kids do for big muscle movement? Tricycles, bicycles, ball pits. What are those trampoline jump places? All of these things are big motor movement. Also, if you can get a good physical therapist in with you and you talk about gross motor movement, if I can incorporate a gross motor movement program, I can get a kid to sit in a 10 for quite a bit of time. Because they just moved, the body knows where it is in space, it can now sit and calm, and I can usually get an attention span to help facilitate what I need to do. When I went to college, everybody said, get them before physical therapy because they're exhausted. My thing now is get them after PT because they're calm enough to work for me. So that's just one of the things we do working together. So lower extremity weakness, we talked about upper extremity for OT, lower extremity for physical therapy. You don't isolate a child. We look at a child from head to toe. When a patient comes into my clinic, I look at that child from head to toe. How are they walking into my clinic? How are they moving? How are they breathing? How are they reaching for things in my office? I look at all of that. So it's total body. If I know if I need to refer out to PT or OT, I can, and I will. And I do that. PT also works on balance. You'd be surprised at what people can't do on an exercise ball. Just very simply sitting on an exercise ball. If you don't have core strength, it's not going to happen. And if I don't get the core strength I need, sometimes I can't get other things that I need to happen for patients. Adaptive equipment as well. Walkers, wheelchairs, canes, braces, knee braces for back support. Just something as simple as and I say simple, I shouldn't, as a foot lift. You know, people have leg length discrepancies. And so when you walk, you're actually using a different hip pattern. So something as small as a 1/4 inch leg discrepancy can make your back hurt at the end of the day. Physical therapists can do that. Just a small piece of adaptive equipment to help you out. And then of course, wheelchair assessments. Usually they get with a DME, durable medical equipment provider, and then put it all together. And so usually our team had a PT and OT and a speech pathologist. We talked about positioning, we talked about respiration, we talked about eye gaze, we talked about communication, but we talked about mobility. Where are they gonna get this chair? How are they gonna get this chair? How are they gonna get it in and out of their house? How are they gonna get it in and out of school? All of those things. So wheelchair assessments, PTs and DMEs usually head that team, but it is a team. The parent, the patient, the rehab specialists, all of us are in there trying to make this work for kids. And that is a very brief overview of PT and OT. So if you have any other questions, you can feel free to contact me. My information will be in, I'm sure, at the end of the presentation. Anyway, I just want to open it up for questions now. Are there any questions? I know you had one, so ask it, please.
How is support for the dieting diets? Any for the speech?
Okay, the question was, how is there support for diets and speech? So I am not a nutritionist. But I do know, I've worked with nutritionists in the past, and I can put together a variety of foods, but amount, intake, and input, I usually consult the physician to seek a nutrition consult. So that you can get, so if they need 500 calories a day, how do I do that? If they need 1,000 calories a day, how do I do that? So when you get that number from a nutritionist or a dietitian, then that information, and I can provide ways to help you, and so can the dietitian. I'm not discrediting them, but if they have problems getting it in, then sometimes I can work with stability and things like that for them to eat more. Dietitians also know of ways to add calories and protein to diets to help facilitate those dietary needs as well. Excellent question. Thank you. Anybody else have questions?
What about maybe having teenagers, the mumbling problem?
Okay.
I mean, if there's truly maybe there's an issue with, maybe they just don't want to speak. That's one thing, right?
Right.
But if they're just discovering, is there truly a speech reason for that?
So the question is, what about older kids who just mumble, or who don't speak as clearly as you think they should? And just to kind of put a thing on that, parents don't always notice, because number one, your child does that all the time, and I understand what they say. Number two is they talk constantly, and I need 2 minutes not to hear it. It just, we're all parents, okay? I mean, we have parents who have these issues and they're real. However, with mumbling, there may be a clinical reason. So sometimes, remember I talked about that grading earlier. So the jaw sits here. So my tongue's not moving very far, and my lips stay here. And so literally, it sounds like mumbling. Or when they do open their mouth, because they haven't done a lot of manipulation or opening their mouth and having tongue mobility, the tongue kind of just sits there. So one of the things I talk about is kids that mumble sometimes sound like literally they have a big old marshmallow in their mouth. And you understand most of it, so you got the point across, so we're good. So you get the meaning, but not all the words in the message. And so that is actually something I work on because I work on grading. How do I get that jaw to open and close just a little bit? But I look at everything that goes with that. Is there jaw pain? Is there TMJ? Do I need to refer to a dentist or an orthodontist? Do I need to, in some instances, it's just tongue mobility. The tongue's not used to moving outside of its comfort zone. It can, but it doesn't. So how do I make them aware, and how do I get them to do that? So it may not be perfect, but I can improve it. So that because sometimes kids they don't because they're shy. They are introverted. They don't want to be, make a show is what my brother used to call it. Make a show, make a show. That's not their personality. But if you get them speaking clearer and better, and people don't ask them to repeat as much, it improves self-esteem, it improves self-confidence. They can actually raise their hand and answer in class, and it improves the rapport and the involvement of them in some of the activities that they're in. Great question, thank you.
So I see on our Facebook Live we have a question. Please give your contact information. So just for those listening, and I'll post it as well.
Okay.
But so they can see it. But if there's your website, phone number.
Let me hang on. I'm moving the camera.
There we go.
You may not be able to see it, but if you can still it, you can get it. My name is Paula Broussard, licensed speech pathologist. I'm the owner, but not really. I am a licensed speech pathologist, and I do patient care at Speech Pathways Plus. We are located in the Bel Air area. Our phone number is 713-660-8232.
Okay, and here I've got, there we go. There is her contact information, and I'll post it as well after the video here. But if there's any other questions on Facebook Live, feel free to post it now, and we'll ask Paula while we have these last couple minutes. But any other questions anybody else has about speech, the PT? I was just fascinated just to learn about the interconnectedness of speech and occupational therapy, and just I guess when we think about it, I usually think about it as separate things, not that they can really all work together.
Right.
So that's what just really stands out to me.
So I just want to say thank you so much for your time and attention today. Is there any other questions?
Please contact Paula if there are. Thank you so much, Paula. I appreciate your time today. Thank you.
Yes.